Good evening, everyone, and welcome to our webinar on ear, nose, throat and treatment. My name is Morella, and I'll be your host for this evening. Our expert presenter is consultant ENT surgeon, Mr. Robert Hone. The presentation will be followed by a Q&A session. So if you'd like to ask a question during or after the presentation, please do so via the Q&A icon, which is on the bottom of your screen. This can be done with or without giving your name. If you would like to book your consultation, we'll provide the link at the end of this session. Please note this webinar is being recorded. I'll now hand over to Mr. Hone and you'll hear from me again shortly.
Good evening. Thanks very much for joining this Q&A session. I'm Robert Hone. I am an ENT consultant in East Kent, and I qualified for medical school in London back in 2008, and I've been doing, well, surgical training started for me in 2010, and I was a consultant, appointed as a consultant around 3 years ago, and I did a Masters of Surgery back in 2015 during training part-time. So I did my fellowship as well at East Grinstead, and I trained all over the southeast and London. So this session is going to cover some simple diagnoses in ENT, some of the more common winter ear, nose and throat symptoms. We'll discuss sinusitis and nasal blockage and how we manage those, as well as sort of more chronic rhinitis, which can go on all year. We'll have a discussion about some of the structural problems in your nose, which often, if you end up having surgery for your sinusitis, need to be fixed at the same time, and some common ear problems as well. Some of the main conditions we often see are reduced hearing, which is usually secondary to coughs and colds, which will be more common in the winter. We do get blocked ears, and again, that's often due to the eustachian tube getting interrupted from inflammation within the nose, and you often feel that your ears are popping or muffled. We see a number of ear infections, usually very treatable with antibiotics, and sometimes we see tinnitus as well, because when you get the popping and muffling or changes in your hearing, you often detect your tinnitus at that point. With regards to your nose, a blocked nose is very common with any cough or cold, but you do have the more chronic problems such as rhinosinusitis. Following colds, you can get typical sinus infections, and these can be short-lived and very treatable with simple antibiotics and topical treatments, or sometimes they can be persistent and more difficult to treat. We do see headaches and facial pain. In ENT, we tend not to deal with headaches, and it's really differentiating between headaches and pain from your sinuses. Hay fever, we don't really see in the winter, but generally it's a part of an allergic rhinitis, which is where an allergy is causing your symptoms, and you can get that all year round. Sleep apnea is more in children over the winter, and when they get upper respiratory tract infections, because their tonsils and adenoids tend to get inflamed and they get some problems with their sleep. We see a lot of sore throats and tonsillitis, for which there's a number of causes. So most of the sort of common conditions we'll talk briefly about are upper respiratory tract infections, of which there's many. I've mentioned and put a slide in on COVID-19, as it's fairly topical, and obviously we're probably going to see some rates increase, so I don't think we'll have any problems with lockdowns again. We'll talk, as I say, about sinus infections, ear infections. Obviously there is cold and flu, and then there's sort of strep throat is obviously in the news a lot at the moment, and tonsillitis. So upper respiratory tract infections covers any infection of your upper respiratory tracts. Now, obviously, we all know about the common cold, but there are numerous different viruses. COVID-19, tonsillitis would fall into an upper respiratory tract infection as well. And we often see, they usually present with a simple sore throat, which gets worse for a couple of days, then resolves, and you break out into your nasal symptoms, which starts with initially stuffiness, a blocked nose, and a lot of rhinorrhea or nasal discharge. And these usually last around 3 to 5 days before your nose starts to dry up, and you start to get dryness, crusting, and irritation, which settles over sort of a week to 2 weeks. you tend to get the systemic symptoms of a bit of tiredness, lethargy. You can have the temperature, and some people get headache and even muscle aches. And I think it's just important to mention that managing these symptoms when you have a cold is important to potentially try and prevent some of the later problems. For example, making sure that you can use decongestants if your nose is particularly blocked. That'll help with your sinus drainage, and obviously maintaining good hydration, making sure you take your pain relief often settles a lot of the sort of more persistent throat symptoms that we sometimes see, such as chronic throat clearing and persistent irritation, as well as laryngitis, which we do see particularly after COVID, and I'll talk a little bit about that later. So tonsillitis, we do see a lot, and certainly it increases over the winter. 90% of tonsillitis is viral in origin, so it doesn't need antibiotics. The picture at the top here shows quite large tonsils, and these sort of white yellow spots are pus on the tonsils. Around about 10% of tonsillitis is bacterial, although some viral infections do tend to have bacteria superimposed onto them, and that's why you don't necessarily need antibiotics with every bout of tonsillitis. They tend to present with a severe sore throat, which can sometimes go into the ear, and it's a matter of keeping on top of your pain relief and making sure you maintain hydrated. You will have, again, systemic symptoms such as tiredness and fever, but as long as you're eating and drinking and managing your pain relief, you don't necessarily need any further help. We do see admissions into hospital where patients can't eat or drink at all, and they tend to come in for some intravenous antibiotics, and actually we give them a couple of doses of high dose steroids, which reduces the inflammation significantly and gets them eating and drinking again. The photo at the bottom is more of a viral type of tonsillitis because there's no obvious pustules. However, here you can see this right hand side is pushing the uvula, which is this dangly bit in the middle, off to the opposite side, and there's a lot of swelling here. Now, this could be a quinsy, which is essentially an abscess which forms between the tonsil and the muscle of your throat, and they're very painful, and they tend to present with a hot potato voice and definite pain radiating or moving to the ear. And they often do need to come into hospital because people tend to struggle to eat and drink. And what you need to do is you just need to get the pus or the abscess out from the side here. Now, if you're having a lot of admissions to hospital with tonsillitis, or if you're getting a lot of tonsillitis, we could take those out, and we do tend to do that. In the NHS, the guidelines are quite strict, but they can be more flexible in the private sector, depending on how severe your episodes are. And certainly if you have at least more than one quinsy or peritonsillar abscess, we would definitely recommend having your tonsils removed, because if you've had two, the chance of you getting another one is around 25%. And the tonsillectomy is a fairly straightforward procedure where we do everything through the mouth, so there's no scars, and you literally just remove the tonsils. It takes about 10 to 15 minutes of operative time. Now, the guidelines do vary, as I say, but as a general rule, it's around 7 episodes in 1 year, 4 for 2 years in a row, or 3 for 3 years in a row, or complications of tonsillitis. So you do have to have quite a bit of tonsillitis to be eligible, and that is because sometimes you do get runs of tonsillitis, and I have seen patients who have had 5 or 6 episodes in 6 months. They come to see you and you say, oh, well, you're getting a lot, we'll list you, and you see them 6 months later, or even longer now, for their operation, and actually they haven't had any more episodes, it's just stopped. So that's the reason for they want the regular episodes. So COVID-19 causes a lot of ENT symptoms. The obvious one that I think most people probably know about is the anosmia, or loss of smell. And that was one of the sort of defining symptoms of COVID. And when it was first added, it was probably the most reliable of all the sort of main symptoms of high fever, cough, temperature, and loss of smell. The one that if you had it, you were likely to have COVID was loss of smell. And the British Rhinology Society released guidelines on anosmia. And if you have COVID, and if you've had it for more than 3 months, you can be referred to ENT, but we tend not to do an MRI. If you don't have COVID and you lose your sense of smell, you can be referred within 4 to 6 weeks. And to be honest, the a lot of anosmia is just excluding other causes as to why you might have lost your smell. And sometimes if we can't find anything, we will do an MRI just to have a look at where the nerves of smell come through from your brain into the nose to make sure there's nothing going on at that point. Laryngitis, as I said, is very common following upper respiratory tract infections, and essentially your voice gets dry. When you get a slightly hoarse voice, you start using your voice slightly differently and it gets hoarse. And again, the British Voice Association, particularly with COVID, released guidance on how to look after your voice and treat laryngitis after COVID, because it can be raspy and husky, and also people tend to throat clear for some time afterwards. It is essentially something called vocal hygiene, which talks about just maintaining good hydrational status, avoiding lots of hot and caffeinated beverages, as well as fizzy and sugary drinks. And you can also use steam inhalations and making sure you don't overuse or strain your voice. Tinnitus has been shown to increase in COVID. However, I say that with a caveat, because obviously when COVID started, everyone was very anxious about it. And there was a concern that actually the tinnitus might be increasing because people are more concerned about their symptoms. And it was an exacerbation of a pre-existing tinnitus. Balance disorders and sort of disequilibrium, where you feel like you're on a boat, or vertigo, can be caused by any upper respiratory tract infection, and notably as well in COVID-19. And some people noticed hearing loss. Just anecdotally as well, speaking to colleagues and friends around the region, we also noticed that we were getting a few additional nerve pauses going, which are the nerves to the voice box, and we feel that COVID may have influenced that as well. So this slide shows quite simply the anatomy of the sinuses. You have a number of sinuses within the nose, and these build up mucus as well, and they do drain the mucus. And you can see here, you've got your frontal sinuses above your eyes, you have maxillary sinuses above your nose, below your nose, sorry, in sort of on the sides of your nose, and you have your ethmoidal sinuses, which are just to the center of your nose, between your eye and your nose itself. Now, when you have an upper respiratory tract infection, cold, or even rhinosinusitis, the lining of the nose gets very inflamed, and that includes the lining within the sinuses, which is why when you have a cold, you often feel that you have pressure under your eyes or around your eyes, and you feel very congested. It does cause the pressure, and often when you lean forwards, that's the pressure pushing on the lining and causing that discomfort. Now, normally, your sinuses drain the mucus out of this area here, which is called your osteomeatal complex, and you will drain the mucus away, and you shouldn't have too many symptoms. And this is where when you have a cold, using a decongestant such as Otrivine or Sudafed can help open up these pathways, because it reduces the inflammation around the areas, allowing your sinuses to drain. And you can use that for sort of up to 2 weeks really with a cold, but ideally no more than 1. And it will hopefully help a lot of your sinus symptoms. What can happen is, particularly if your sinuses get infected, inflammation in this area blocks the drainage pathways, and you get persistent buildup of mucus, which is quite hard to shift. And that can lead to notable infections and excessive discharge, or you can simply get sinus pain and pressure. So what are the symptoms of a blocked nose and sinus symptoms? So to have chronic rhinosinusitis or rhinosinusitis, you have to have really a blocked nose with sort of nasal congestion or blockage, and you have to have discharge. Either one of those has to be present. And the blockage really has to be fairly persistent and on both sides of your nose. Some people do have blockage on one side of the nose at all times, and it's called the normal nasal cycle, where one side of your nose rests and the other is active, and therefore one side of the nose is always slightly more blocked than the other, which is why we tend to make sure it's persistent and not alternating between sides. The discharge from your nose can go down the front or back, and it can either be clear or even infected. Now, interestingly, the commonest cause of the feeling of mucus dripping down the back of your nose, if you don't have anterior or frontal nasal discharge or a blocked nose, is often actually indigestion, where sort of your stomach contents come into your throat and it causes thick mucus and makes you feel like things are dripping down the back. So it is important to have those symptoms. Facial pain and headache is a common symptom of sinus infection or blockage. And classically, it's worse on leaning forwards. Again, it's important to make sure you have either discharge or a blocked nose, because without those, I would suggest that it's more of a sort of neuralgic, atypical facial pain. Again, with sinus problems, you will potentially have a reduction in your smell. Often taste seems to be preserved. If you have sneezing and itching, and you may get watering eyes, but if you have sneezing and itching of your nose, classically that is an allergic type of reaction or an allergy that's causing the inflammation in your nose. Nosebleeds can occur, and that's often due to dryness, although I would say with chronic rhinosinusitis, you tend to get a bit of blood-stained mucus rather than a frank nosebleed. If you're getting frank nosebleeds, it's less likely to be related to the inflammation in your nose. As mentioned, you do often get blocked ears and muffled hearing, and that's because the tube between the back of your nose and your ears can get blocked, and your ears don't ventilate as well, so that you feel like you're persistently underwater, or just like when you have a cold and you can't hear quite as easily. You can get a watery or itchy eye, and again, that would suggest an allergic type picture. So how would we diagnose whether or not you've got chronic rhinosinusitis or inflammation in the nose? This is one of my colleagues, and he's performing what's called a nasal endoscopy. We have now, since COVID, which has been it's allowed us to progress our equipment quite well, because we now have to have video equipment, which allows us to see everything on the screen and patients to see what we're looking at if we find anything. But we have a little 3mm fiber optic telescope with a, well, it's not fiber optic anymore. It's, you've got a little chip in the tip, and that relays the images to the screen. This is called a fiber optic nasal endoscopy. It is very small, and it is a little bit uncomfortable, and it can make your eyes water. But we would have a look at the front of your nose with simply a headlight to see if we can see any obvious from the front. And then we do pass this camera along the nose. And here in this picture, you can see this is going down the patient's left-hand side. And that's what's called the turbinate, which helps warm and humidify air. And these can also be inflamed and enlarged. And that's heading towards the back of the nose. And we would have a look around, and we would check that osteomeatal complex to make sure it's open, or if there's any pus or a lot of inflammation there. If your nose does get hugely inflamed, you can develop something called polyps, which is where the lining of the nose swells so much it hangs down from the nose, and these can be particularly problematic and often need surgical removal. This little camera can go all the way through the nose to the back of the nose to check the area that where your eustachian tube opens at the back of your nose, so we can see if they're blocking the eustachian tube to your ear. And this picture here is of this patient's voice box, so we can have a good look at your vocal cords, make sure that everything in your throat is healthy, particularly if you're getting lots of catarrh, or that your voice is changed. And with the new cameras, the definition's excellent. You can get very good views to see if there is anything going on in the voice box, and it's really fundamental part of the ENT examination. If when we've seen you in clinic, examined you, we feel that we would want to do further investigations, the most common one to look at your sinuses, especially if we're thinking you do have sinus disease, is a CT scan, which is this scanner here, which is like a donut. It's not an MRI, so it's not particularly claustrophobic, and it's quite quick, and it produces images of your sinuses and whether you have inflammation in there. We can do allergy tests. We often used to do skin prick tests, but we tend to move on to blood tests now to look at your total IgE level, which is a marker of how much of an allergic reaction is occurring at that time. And the RAST is to specific allergens. So we generally test for house dust mite, which obviously will cause an allergy all year round. and grass, trees, and often sometimes mold, as well as certain foodstuffs or pets as well. And as mentioned, we may well do the diagnostic endoscopy. So if you have permanent blockage and discharge in your nose, it can be either allergic or non-allergic. There's a lot of different classifications, but this is some of the easiest, and it can be intermittent or persistent. So this is seasonal or all year round. And allergic rhinitis is more associated with asthma or atopy or any other allergic. If you've got other allergies, you're potentially more likely to have it. You may get triggers where, for instance, in the summer, even patients actually going to bed at night notice the symptoms get worse, and that's if they're allergic to house dust mite, because dust is in their pillow. And you tend to get a reaction where you start sneezing, and you often have an itching nose, and you produce copious amounts of generally quite clear watery discharge from your nose, and you may also have itching eyes or watering eyes. Non-allergic chronic rhinosinusitis tend to be more of a purulent discharge, and you're more likely to get more facial pressure and pain rather than just copious discharge and blockage. You can get polyps with either. So how is it treated? Well, most patients get treated medically, and I think there's a number of different guidelines on the treatment, and it does partially depend on the cause. Obviously, if it's allergic, you want to try and do allergy avoidance. But the mainstay of treatment is nasal drops and sprays. And these tend to be using a topical steroid spray. The modern steroid sprays, because I know people worry about steroids as a medication, they tend to be topical and not systemically absorbed. So most of the common ones we use, only about 0.4% is systemically absorbed, and that tends to be, and they're in low doses anyway. Some of the older sprays, it is higher. The other thing that's particularly useful is something called a nasal douche, and this is particularly useful again in allergic symptoms. And there's two that I would generally recommend. One is something called Sterimar, which you can buy in the chemist, and is literally a saltwater spray, and it helps lubricate the nose, washing out secretions, and it also washes out the allergens. So for example, if you went out in the summer and you had an allergy to grass, the grass pollen goes up your nose and it causes an allergic reaction. If you were to wash that out, it would reduce the amount of reaction and reduce your symptoms. And the other one, actually, which if you can tolerate it is better, is Neilmed Sinus Rinse, and that is literally a bottle of salty water that you spray up your nose to wash the pollens and irritants out. Targeted antibiotics are important when you have an infection. You wouldn't necessarily use those for allergic. They would be for non-allergic, to treat a number of different bacteria, and they tend to be for fairly long courses of up to 4 weeks, sometimes even longer. Antihistamines are very useful in, again, hay fever. In non-allergic rhinitis, I wouldn't give an antihistamine. My one caveat with using antihistamines is I remember when I was training, I had a very good lecture on one of our academic days, and someone put up a lot of data on antihistamines and drowsiness, and even the modern non-drowsy ones, they can affect concentration. So I tend to just say to people, use an antihistamine when required, when you sort of get an attack, or you've come into contact with the allergen, to reduce your symptoms, rather than doing it every day. But that's personal preference, and you can certainly use them every day. And as mentioned, if it's untreated, the inflammation can get so severe that you develop nasal polyps, and also it can cause worsening of your asthma. And this comes down to what is now being termed reactive airway disease, where we know that your noses, your throat, and your lungs are all connected. And obviously, if you have asthma that is reactive to allergens, then your nose may be as well. So controlling your nose often helps your asthma symptoms. I'm briefly going to talk about structural problems in the nose, and the only reason to really talk about this is because sometimes if you do need sinus surgery, this will need to be fixed. It's not obviously any worse in the winter months, although some people do feel that when they get a cold, one side is particularly badly affected and blocked compared to the other, and that may be because the septum is bent off to one side. You can see here that this septum is the middle part of the nose, and it's made up of cartilage and bone, and it runs between your two nostrils all the way to the back of your nose. It can cause narrowing, which can make you feel that your nose is obstructed, and that would generally be persistent. You can again try treating this with a simple spray, and if it helps, then you potentially don't need this correcting. It can be treated on its own, even if you don't have rhinosinusitis, and you can do something called a septoplasty if someone's persistently blocked due to a bend. The inferior turbinates, I said, you often see them sitting in the nose just down here, and they help warm and humidified air. If your septum is bent, one of those may be enlarged, or again, if you have inflammation of the nose, they can be enlarged, and we can reduce those to help. One is to improve your nasal airway and help you breathe. The other is it does tend to mean you get a little bit less secretions as well. This is a CT scan of your sinuses, and it demonstrates very clearly fluid within the sinus. So air on a CT scan appears black, and this is called your maxillary sinus, which is the one that sits under your eye, which is just here. And this is the inferior turbinate we were talking about, which looks a little bit enlarged. And you can see that all of these air cells on the right are nicely aerated, and there's no obstruction, no fluid filling them. However, on this left-hand side, it's gray, and that is the same color as soft tissue, and it suggests that there's fluid within here and that there's probably a blockage at this point, which is the osteomeatal complex, which is why the fluid's filled up, and that will be causing potential infections, discharge, pain, and the feeling of blockage on that side. Interestingly, the CT scan also shows a big bend in the nasal septum, and you can see this bony strut sticking out, and that is probably partially contributing to the blockage of the sinus here, because it's poking up into the area where it would drain, and any cold would increase that inflammation and really block this sinus. And I have to say, we do see that quite a lot. So this patient would probably need what's called functional endoscopic sinus surgery, where we would go in, we would open up the sinuses to let them drain, wash them out, probably remove this big strut here and straighten the center of the nose. And this picture on the right shows exactly that. You can see the gap between the sort of wall of the nose and the sinus is very open, and the sinus is drained. The septum here, the middle bit of the nose, is very straight and is no longer causing a blockage on that side. And both sides show that they've got air, and this side you can see on the right, this is the right hand side, you can see that they haven't necessarily opened the sinus, it's just been done on one side. And that patient would almost certainly have very good symptomatic relief. Moving on to the ear, I'll give you a little bit of information on the anatomy of the ear, and it's broken really up into three parts. So you've got your earlobe here, which is called your pinna. This goes into your ear canal. You've got your eardrum, and then behind your eardrum, you have something called the middle ear. And that connects you to the eustachian tube, which runs all the way to the back of your nose. Beyond that, you have your inner ear, which houses something called your cochlea, and your vestibular system, which controls your balance. And you can see these three semicircular canals, which are little loops which tell your brain which way your head is moving and along which axis. And therefore, we break things up into the three areas of outer ear, middle ear, and inner ear. And within the middle ear, you have your bones of hearing as well, which are these three here. And we'll talk a little bit about the different causes of hearing loss and what can give you problems. So the main things we see in clinic are hearing loss, which there are a lot of causes for it, ranging from fluid behind the eardrum, a blockage in the outer ear, or just general wear and tear of the inner ear. Tinnitus is a ringing in the ears, or in fact, I'll clarify that. It's any noise which potentially you hear that other people can't, and there's no external source. So It's classically high-pitched ringing, but it can be a whooshing, or it can even be pulsatile. If it is pulsatile and in time with your heartbeat, we'd want to see you because we'd want to potentially do a little scan to make sure there's no sort of blood vessels pressing on the nerve. You may get some pain in the ears. Pain is classically associated with infection or fluid behind the eardrum, causing a pressure on the eardrum. If you get discharge, that once again generally points to an infection, and that can be in the outer ear or from behind the eardrum when your eardrum bursts. And if you do have an infection behind your eardrum, the pain will get worse. And then when you get the discharge, classically the pain gets better because the pressure is resolved as your eardrum's perforated and made a hole, and they're nothing to really worry about. Most heal on their own very quickly. Balance problems such as dizziness and vertigo is usually due to the problems with the inner ear and around the cochlea and the vestibular system. So what are the common problems in the outer ear? Well, we do see wax, which causes a blockage in the outer ear. It can cause pain if it gets infected, but it will potentially cause hearing loss because it's like putting your finger in your ear. It generally doesn't cause any problems, although it can be quite tricky to remove, and we can do that very easily in clinic. Infections of the outer ear are very painful, and they can cause discharge as well as muffled hearing, similar to putting a finger in the ear. That's what the hearing loss will sound like. The ear canal can swell, and that's along with the discharge, that's what causes the blockage. Very rarely we'll see, well, not very rarely, in children we see quite a few foreign bodies in the ear, but sometimes your hearing aid mold can come off, and you shouldn't put cotton buds in your ear, but again, some people do. I can still remember a case when I was quite junior. A man came in saying, oh, my ear's blocked, and we removed a cotton bud, and then 5 cotton buds later, we'd managed to clear them all out of his ear. The middle ear, so that the conditions we discussed affect this area here. The middle ear here, you may get eustachian tube dysfunction. Now that is where your eustachian tube here, every time you swallow or yawn, you potentially open this tube and air can get into the middle ear area here and help it ventilate. When you get a cold, this can get inflamed at the top and it can feel blocked and muffled. And that's exactly the same as when you're on a plane. When you go up and down on a plane, you're just struggling to change those pressures quite so easily, or when you dive. So you can do something called a balloon eustachian tube turboplasty, which is where you cannulate, which means just thread a little wire through this tube and you inflate a little balloon to open it, as the symptoms can persist after a cold. Now, the evidence for it is variable, and it's to be used in selected patients only who fit the criteria. And we generally do a questionnaire before we would go down that route. Glue ear, which is fluid behind the ear. Now there's 2 types really. It's quite serous fluid, which is quite thin fluid, and that's called a middle ear effusion, or glue ear where it's quite thick. If you have that, that can reduce your hearing and cause recurrent infections. And we would make a little cut in your eardrum and drain the fluid out to try and improve your hearing or prevent future infections. There are some nasty infections called a cholesteatoma, which is where your ear doesn't clean itself and a ball of skin builds up and essentially, unfortunately, it dissolves the bone in the area. It can it can be treated, but it's a bigger operation. And sometimes these ossicles or bones can get disrupted so that the transmission of sound from the eardrum doesn't go through the bones down to the cochlea, and you get a drop in your hearing as well. The inner ear tends to be what's called sensory neural hearing loss, whereas the middle ear causes a conductive hearing loss. So you can test that the nerve is working and whether the eardrum is on a hearing test, and you can differentiate between the hearing problem in the middle ear and the inner ear. But we often see age-related hearing loss. Commonly noise-induced hearing loss is quite common, and your hearing test will classically show a drop at a specific frequency for that. A number of medications can drop your hearing, as can trauma. And there are some other conditions as well, but I'm not going to go into all of those at this point. Vertigo, we see a lot of vertigo, and vertigo is specifically the illusion of movement. And it's important to clarify that as the symptom, because you can get disequilibrium, which is simply the illusion or the feeling of unsteadiness. And the two are very different. In ENT, the main ones we see is Meniere's, which is very rare, BPPV or benign paroxysmal positional vertigo, which is usually very short-lived vertigo moving your head, labyrinthitis, which follows a cold, and vestibular migraine. We see a lot of multi-level vestibulopathy, which is essentially multiple areas of your balance system are affected, and that's often in older patients. And then rarer things such as persistent postural perceptual dizzinesses, where you get it in certain scenarios, and superior semicircular canal dehiscence, where this little semicircular canal is not formed properly, and it can cause some dizziness as well. And in very rare instances, you can get a benign tumor on the nerve of hearing, which can cause hearing loss, tinnitus, and vertigo as well. In clinic, we can happily remove wax from the ear canal. We use a microscope and a little hoover here. It is noisy and can be a little uncomfortable, but it shouldn't be painful. Rarely it can make you a little bit unsteady on your feet afterwards, but that is very uncommon. And we offer hearing tests in a soundproof booth to assess whether your hearing is reduced as well. And we can also test for the fluid behind the ear with a pressure test. So that's the end of my talk. If anyone has any questions, I'd be delighted to take them.
Thank you, Mr. Hone, and that was a really interesting presentation. We'll now take some questions. We have a couple in the Q&A box. So the first question is, I have suffered with earwax problems before. I'm wondering what your thoughts are on ear hygiene, including cotton buds.
So I would say definitely do not use cotton buds. Cotton buds are problematic for a number of reasons. The first is that they tend not to clean your ear. They tend to just push wax deeper into your ear. They also tend to cause sort of micro trauma, and that can cause infections as well. And obviously, lastly, the end of the cotton bud can come off and get stuck in your ear. Your ear should self-clean itself, actually. The main thing that means it often doesn't is that the wax can be a little bit dry. As a simple thing, you could just put a drop of simple olive oil in your ear once or twice a week to try and keep the wax loose, and it should work its way out. The only problem is obviously you start putting too much, it gets too wet, and can obviously give you symptoms of there being sort of water and fluid in your ear. I think it is difficult because some people do need regular microsuction for their ears because they do get blocked. And obviously, if you're a hearing aid user where you're constantly putting the tip of your hearing aid in your ear, then potentially you will need more regular microsuction or cleaning out of your ears as well.
Okay, thank you very much. Next question. I experience bouts of dizziness for short periods a couple of times a week. At what point should I seek advice?
I would probably seek advice now. I think again, it depends on the dizziness. Sort of vertigo, which is the illusion of movement in the room spinning, that's more ENT. If it's the feeling of being on a boat or at sea, that's disequilibrium. Or if you feel lightheaded, then that's something to go and see your general practitioner about. I mean, it's dizziness or balance disorders are quite complicated, and it's all in the history really as to what the potential cause would be. But if you're getting bouts of true vertigo which occur a couple of times a week, it might be that you can come and see someone, and we can certainly rule out a few things, or maybe if it is BPPV, treat it very easily in clinic with something called the Epley maneuver.
Okay, thank you. Next question. When I was a teenager, I had surgery inside my nose to help breathe in due to swelling. Now in my 20s, I still find I breathe through my mouth mainly. Should I seek advice?
I mean, so you certainly can do. I think if you've had surgery and it hasn't helped, then maybe there is still an ongoing problem. There's a number of other reasons, as well as your septum or the centre bit of your nose, that can be blocked, that can mean you do stuff with mouth breathing. But I think that would be perfectly reasonable to do that.
Okay. Next question. I take antihistamines most days. I don't generally have drowsy side effects. Is it safe to continue doing this?
Um, yes, I think so. If they help your symptoms and you feel they're the thing that controls your symptoms, then absolutely carry them on. As I said, I just tend to be a little bit more cautious, and I'll try and control nasal symptoms with douches and sprays. But lots of people are on antihistamines long term. It's yes, that's fine.
Okay. Next question. Can a fess be done on both sides, i.e. the left and right sides in the same surgery, or are separate fesses required?
No, we can definitely do a fez on both sides during one operation. And obviously, if you have symptoms in both sides of your nose, we would definitely do both sides at once. That scan was just because it showed one side only, and that's why. And to be honest, they had a clear septal bend, which was probably a significant part of their problem. But yes, definitely you can do it on both sides at once.
Okay. One last question we have. So a patient has a very itchy right ear over 2 decades, which has now improved with dexatricin. Apologies, I can't pronounce that. However, there is now increased episodes of sudden muffledness and low buzzing. Could this be many ears, or how can it be verified?
So I wouldn't have thought itching would be Meniere's. Itching in the outer ears is often due to dry and flaky skin, or often getting water in your ears. The biggest thing really for itching is actually after showering, people get water in their ears, and it does irritate the ears, particularly soapy water or shampoo. Was it muffling, they said, or getting some tinnitus. So tinnitus on its own, I mean, Meniere's as a cause for tinnitus is rare. It does cause it, but actually it's much more likely that it's either a little bit of hearing loss or there's another cause in the history that would be the reason for the tinnitus.
Yes, and they mentioned the improved with the dexatricin.
Yes, so I don't know exactly what that medication is, but the dexatricin sounds like it's got some dexamethasone in, which is a steroid. And again, if there is some eczema or dryness in the skin of the ear, that will potentially help or would have helped.
Okay, thank you. So that's all the questions that we've had in this evening. So thank you to everyone that's asked those questions and attended the webinar this evening. If you would like to book your consultation, then do contact us on the number on the screen between 8 AM and 6 PM, Monday to Friday. We are offering a discount for those that are joining this session with the terms on the screen. You will receive a short survey, and I would be grateful if you could spare a couple of minutes just to let us have your feedback. Our next webinars are in January, and they include weight loss surgery, orthopedics and gynecology. And you can visit our website to sign up for these and find out some more information. So on behalf of Mr. Hone, myself and the team at Benenden Hospital, I would like to say thank you very much for joining us this evening, and we hope to hear from you soon, and have a very good evening. Thank you and good evening.
Bye-bye.
Bye.